Hello everyone, my name is Sayed and I will be presenting patient case. We have a 47-year-old female who presented in emergency department with a history of metastatic colorectal cancer. Patient has severe nausea, vomiting and diarrhea 10 days after chemotherapy. Patient also have inflammation around chemotherapy port along with fever, chills, shakes and worsening confusion. Patient has been also complaining about calf tenderness for over a few weeks. The past medical history includes hypertension, CKD, obesity, colorectal cancer, and prediabetes. Patient does not have any medication allergies. The medication she's currently on include lisinopril 40 mg PO once daily, metformin 500 mg PO twice a day, ondansetron 8 mg PO every 8 hours as needed, dexamethasone 8 mg PO daily for day 2 and 3 of the cycle, and oxycodone 10 mg every 4 hours as needed for pain. We don't have any pertinent social or family history. The priority list I made for her today is number 1 is the septic shock due to central line associated bloodstream infection. Number 2 is DVT. Number 3 is CKD. Number 4 is chemotherapy induced nausea and vomiting. 5 is pain. 6 is dysglycemia. And the last priority list includes hypertension and colorectal cancer. Moving to the assessment of disease of central line associated bloodstream infection, patient has uncontrolled septic shock due to severe complicated Clabsi as per 2009 IDSA guideline. This is evident by the fact that patient has positive blood cultures, have also manifestation of infection such as fever, and her Q-SOFA score of 3 that shows high risk of mortality in this patient. The contributive factor in this patient for development of Clabsi is the chemotherapy port. The preliminary result of the blood culture shows that patient have gram-negative infection. Considering all these factors, there is a need to start an empiric therapy that will eradicate bacteria within 7 to 14 days and minimize the risk of mortality from septic shock. The likely pathogen includes Pseudomonas. Assessment of current therapy, patient received 4 liters of normal saline in an emergency department. Crystalloids such as normal saline is an appropriate choice for initial resuscitation of this patient. Patient also got doses of meropenem and vancomycin. However, vancomycin is not an appropriate choice since the initial blood culture shows the patient does not have any gram-positive infection. The meropenem dose that she got in the emergency department was also not appropriate as she got 1 gram she is going to give 1 gram every 8 hours, which is not the right dose. The assessment of planned therapy, there is a need to stop vancomycin because there is no sign of gram-positive infection. We need to modify her meropenem dose. This will also reduce the stress on her already compromised kidneys. Survival of this patient is dependent on aggressive fluid hydration and early antibiotic use. The goal of therapy is to restore tissue perfusion within 6 hours, to eradicate bacteria in 7 to 14 days, and to minimize the risk of mortality in this patient. The contributive factor includes chemotherapy and immunosuppression. Moving to management of Clabsi, recommendation number 1 is to stop vancomycin and start meropenem in doses of 1 gram IV every 12 hours for 72 hours and then reassess. Meropenem is recommended by IDSA 2000 guidelines for empiric treatment of gram-negative bacteria. Also, the previous lab shows that patient bacteria is susceptible to carbapenems. Empiric use of double gram-negative coverage for patients who are critically ill with suspected Clabsi is also recommended by IDSA 2000 guideline. And this is the reason why my second recommendation include topramycin at a dose of 1 gram IV every 48 hours, and then we have to reassess. Topramycin is also recommended by IDSA 2000 guideline for the empiric treatment of gram-negative infection. Topramycin, among all the other aminoglycosides, have less chances of ototoxicity and nephrotoxicity. The reason for the combination therapy is also early combination therapy also found to reduce the mortality in patients admitted with septic shock versus monotherapy as was found by Kumar et al. In the retrospective study. The contingency plan for this patient is that we need to de-escalate the therapy to one antibiotic and to treat it for 7 to 14 days. We need to consider to remove catheter in this patient if the infection does not improve in 72 hours. And these are the recommendations consistent with IDSA 2000 guidelines. The monitoring includes, for the efficacy, are resolution of signs and symptoms of septic shock within 6 hours, improvement in infection within 72 hours, and resolution of infection in 7 to 14 days. The safety of the therapy and patient can be assessed by monitoring MAP, renal function, liver function, CBC, respiratory rate, and heart rate. Moving to the next problem that patient presented today is a deep venous thrombosis. FC is a confirmed case of DVT in a right vein tibia. This is confirmed by the ultrasound, swelling and pain at that point. The contributing factor for DVT in this patient is her obesity and also her malignancy. Patient does not have any pulmonary embolism, as was confirmed by a pulmonary angiogram. Considering all these factors, there is a need to start DVT treatment to prevent the complications such as pulmonary embolism and post-thrombotic syndrome, and also to reduce the morbidity in this patient. The assessment of current therapy: patient is not receiving any medication for the treatment of DVT. Assessment of planned therapy: heparin in doses of 5,000 international units twice a day is not an appropriate choice as per CHEST guideline for the treatment of DVT. Heparin should be administered at least at 333 units per kilogram as a loading dose, followed by 250 units per kilograms every 12 hours for treatment of DVT. The NCCN DVT guideline in cancer patients prefer low molecular weight heparin, so we can think to switch this patient from heparin to low molecular weight heparin. The goal of therapy is to treat DVT to prevent morbidity and complication from DVT and to prevent future occurrences of DVT. The contributing factor includes obesity and malignancy. The management, starting with recommendation number 1, we need to stop heparin and start deltaparin in doses of 18,000 units sub-Q once daily for 30 days. The rationale: NCCN DVT guidelines recommend low molecular weight heparin versus over ultrafraction heparin. Patient does not have any history of heparin-induced thrombocytopenia, so the low molecular weight heparin can easily be initiated in this patient. Recommendation number 2 is to continue deltaparin for prophylaxis use of DVT in this patient at the same dose of 18,000 international units sub-Q daily as long as the patient cancer is active. And this is recommended by NCCN DVT guideline, who says that if patient have an active cancer, the DVT prophylaxis should be continued if the DVT was caused by non-catheter associated thrombosis. The result of Deltican study also suggests that long-term therapy is optimum and the major bleeding risk is not a concern in cancer patients. We need to monitor her platelets, hemoglobin, hematocrit, fecal occult blood, and sign of bleeding. Efficacy of the treatment can be evaluated by resolution of DVT, prevention of complication of DVT, and prevention of the future occurrences of DVT. Moving to the last problem that I'm going to present today is a chronic kidney disease. The assessment of disease: patient has mortality to severe chronic kidney disease, which is stage 3 according to KDIGO guideline. This is evident by the fact that patient has creatinine clearance of 33 milliliter per minute using MDRD equation. Patient also have CKD complications such as hyperphosphatemia, anemia, and hypercalcemia, and low vitamin D levels. The likely cause for the development of CKD in this patient is previous history of acute kidney injury, chemotherapy, hypertension, and dysglycemia. There is a need to prevent the development of AKI by stopping unnecessary drugs. We need to treat the complication of CKD, and we need to slow down the progression of CKD. The assessment of current therapy: patient was only taking lisinopril for the treatment of hypertension. Lisinopril is an appropriate choice in this patient. However, patient is NPO at this point and not taking lisinopril. The assessment of planned therapy, starting with anemia. Parenteral IVR is not an appropriate choice in this patient, as patient has active cancer, and KDIGO guideline does not recommend using parenteral IV iron in these patients. Also, erythropoietin is not an appropriate choice, as patient iron levels are low. However, we can start the oral iron as soon as patient NBU status removed. The goal of therapy for iron is to achieve the hemoglobin between 11 to 12 grams per deciliter, the SATs of greater than 30%, and we need to maintain her serum ferritin over 500 nanograms and between 500 to 800, and this can be achieved in 1 to 3 months. The assessment of therapy, bone and mineral disease. There is no specific planned therapy for phosphate binding in this agent. However, it is important to know that we cannot use calcium phosphate binders because patient has hypercalcemia. Phosphate binding agent will lower the levels of PTH in this patient. Also, we need to start the vitamin D therapy as vitamin D levels are low in this patient. The goal of therapy for bone and mineral disease in this patient is to normalize PTH levels, calcium and vitamin D levels within 6 months, and we need to reduce the risk of osteoporosis, reduce the risk of cardiovascular problems, and slow down the progression of CKD. The contributing factor for the development of CKD, the previous history of AKI, chemotherapy, and bone and mineral disease are the complications of CKD. Management recommendation number 1: as soon as patient NP status has been lifted, we can start her on ferrexatrate 2 tablets PO 3 times a day as an initial dose. This dose can be increased from 1 to 2 times per week. This will help to achieve target serum phosphorus levels and iron levels. The rationale for using ferrexatrate in this patient is that it is beneficial to improve both hyperphosphatemia and anemia, and it was found by Mei-Yu et al. In a 2017 meta-analysis on 9 RCTs. Ferrexatrate offers phosphate binding without elevating calcium levels. Recommendation number 2: we need to start vitamin D3 in doses of 1,000 units, PO once daily, and this is recommended by KDIGO guideline to lower PTH levels. The contingency plan for her CKD is the parathyroidectomy. In this patient can be considered if the hyperphosphatemia and hypercalcemia is resistant or refractory to medical therapy, and it is recommended by KDIGO guideline. Patient can also be switched to IVRN if the stores of iron are not achieved in 3 months. Start with erythropoietin if sufficient iron levels are not achieved even with IVRN. The monitoring: we need to monitor the efficacy of the treatment by slowing the progression of CKD, improvement in PTH, calcium, vitamin D levels in 6 months, and improvement in anemia in 1 to 3 months. We need to monitor for safety, which includes hemoglobin, hematocrit in 1 month, the SATs and ferritin in 3 months, and we need to monitor her levels of potassium every 3 months if the patient restart her lisinopril. Thank you, and that's all from me.